A very good evening to all. I'm Dr. Uttara Mohan from the IP Digital Media team. We welcome you to this online symposium on innovations in stroke rehabilitation. We are streaming live on IP India YouTube channel. If you miss anything during this session or would like to review the session, you can visit the YouTube channel and replay the session anytime later. This symposium is being facilitated by the support of the IP Digital Media team. This team consists of a group of physios who handle the Zoom platform, live streaming, and IP profiles on social media such as Facebook, Instagram, Twitter, LinkedIn, and YouTube. You can follow us on these social media platforms to get regular updates about our upcoming activities. You can subscribe to the YouTube channel so that you get notifications during the live webinar. We'll be sharing the links of the social media in the chat shortly. So before we start, I would like to tell you about the IAP neurology group. This symposium is being organized by this IAP neurology team. This group represents physiotherapists with special interest in neurorehabilitation, dedicating to advancing the scope and practice of neurological physiotherapy in India. It has been promoting research, evidence-based practice, clinical specialization in neurology, and knowledge exchange. We have conducted a range of various online activities, such as webinars, the symposium, which we are right now attending. We had neuro case studies, interactive quiz sessions on the online platform. IEP is also committed to strengthening the clinical skills and elevate neurorehabilitation across India. With a team of experts formed, this clinical practice guidelines for physiotherapy and stroke was developed by IEP and it was released last year. To receive updates of our upcoming events by IP Neurology Group, you can synchronize the Google Calendar into your Gmail account and will be able to see the regular updates of the upcoming events, including the details of the event and also the links for the joining. We have three speakers for today's session. During the presentation, if you have any questions to ask the speaker, you can post it in the chat box. We'll address them at the end of each speaker's presentation. It is my great pleasure to introduce our first speaker, Dr. Ramesh Debur Vishweshwara. He's an associate professor in the Department of Physiotherapy at MS Ramaya Medical College, Bangalore, and clinical consultant at Ramaya Memorial Hospital. With over 2 decades of academic and clinical experience, his expertise spans across biomechanics, neurorehabilitation, gait and balance assessment, and digital health innovation. He has led multiple funded research projects, holds patents in functional electrical stimulation, has published extensively in national and international journals. He has also collaborated with leading institutions and industrial partners to advance the rehabilitation technology. He's been recognized with several awards, including IAP Research Award, Best Researcher Award. He continues to inspire us through his contributions to physiotherapy education, research, and innovation. He will be talking on the topic targeted therapies in neurorehabilitation, role of technology based intervention. Now I request Dr. Ramesh to please start with his presentation. Thank you.
Thank you, Dr. Uttara, for that kind presentation. And before I start, I would like to offer my thanks to the specialty group, neuro specialty group of the IAP to give me this opportunity to share my views on the topic. Will in the next 30 plus minutes or so, I would like to essentially discuss a few points in the field of neuro rehabilitation. Rehabilitation being a reasonably complex field to work with, has had a lot of early ups and downs, but now seems to have kind of plateaued a little in the last decade or a decade and a half. And there is perhaps a way to look at it a little differently. And that essentially is the objective of my today's presentation. It's more of a concept talk rather than a directed event. Uh, so today I would be discussing about a little bit on the targeted therapies in neurological rehabilitation, the operative term being targeted, and how do we interpret it, and perhaps my point of view or opinion on what is targeted and why is it important. And essentially it is a mechanistic view of things. The word mechanistic also being interpreted in a manner of science, understanding different mechanisms that guide intervention design as well as design of outcome. So we could summarize it as in one line as a method to analyze, intervene, and assess outcomes. So a small correction that I have to make. We are now College of Physiotherapy, and we are Ramaya College of Physiotherapy, apart from Ramaya Medical College over the last couple of years. Though we are still connected, so there's just a small correction that I should have given properly, and there's been a mistake. So with that, I would like to start off with what we define as a therapeutic target. So, in the first half of my talk, I will focus on therapeutic target and targeted rehab. And in the second half, grossly, I would be discussing about the neurological interventions that we do and how we do about it. So, for a therapeutic target, uh, is a biological substrate whose modulation produces a measurable therapeutic effect. So this is a very biological definition, and this is the foundations of a lot of research in the field of uh, biochemistry and pharmacology. So a small deviation from here would be to understand that we are physiotherapists. So when we contrast that with, say, for example, pharmacotherapy, we would see that they come from a different viewpoint. So they are biochemical in nature, which essentially means that they focus on the chemistry of the human body to bring about a change in biology. We, on the other hand, are physiotherapists, which means our focus is physiochemical, which essentially means that we push the biology through physics. So it becomes a physiochemical. The change happens at the chemical level eventually in the human body, but the path taken, if you will, is a little different. So we the word target essentially means it's a substrate, and the substrates in us is neural network based or activity dependent. We'll discuss that in a couple of seconds. So why is this question challenging in rehabilitation, and why should we be discussing uh, targeted therapies in neurorehabilitation? If we were to push back, for example, a couple of decades behind, our interventions have been mostly at the foundation of behavior. It's mostly distributed across neural systems and obviously mediated through plasticity. So, for us, biological targets aren't really very explicit, and therefore, uh, targeting, if you will, becomes a little more difficult to define and express as a problem. So, not just us, even medicine is being increasingly target driven. So the targets there are defined differently, but it does help. In the last 20 or so years, you would see that there's a significant improvement or a change in the number of uh, assessment tools, and both biochemical and radiological and treatment tools, because the focus has turned from behavioral to target oriented. So, for examples in pharmacology, the targets usually are receptors or enzymes or ion channels that are targeted either with biochemical events or radiation and so on and so forth. On the other hand, A surgeon looks at a target that is slightly different. So for them, the target is maybe more morphological in terms of anatomical structures, in terms of tumors and lesions, and so on. So they have a point of view where they can focus on a target, and that particular target would be the target of both assessment as well as treatment. And then a change is brought about that cascades upwards, if you will, into a behavioral level intervention. So for us, usually traditional rehabilitation thinking has been on movement patterns, facilitation techniques, and functional task practice. So we haven't really focused on pure biological targets for variety of reasons, including that when this was started in very early, for example, of Brunstroms and robots, we didn't have the kind of imaging techniques or the kind of study interrogation methods to interrogate the nervous system as well as the current level of biological intervention. So our targets are mostly about a function, though there is a functional target, but it's not really a target in the true sense of the word. We've been mostly goal oriented. So this is not to say that goal oriented treatments aren't effective or aren't useful in today's context, but just that the causal connections are a little harder to understand if we discuss it in that particular sense. So essentially, what is a targeted treatment approach? So, a current intervention model essentially is a symptom to treatment, where the symptom starts off as a given example, and then we say, okay, so this patient has a little bit of difficulty in balancing. So the intervention also tends to be a balance intervention, which essentially, in some ways, is simply a repetition or a challenge task. So a lot of physiotherapeutic interventions that works at a behavioral level are challenge interventions. So if a patient has difficulty in walking, most of the time the intervention translates to some aspect of walking. And if a person has difficulty doing a sit to stand, which and we assess sit to stand for its components, the intervention is a challenge where we challenge the biological system to do a sit to stand and then assist it, resist it, so on and so forth. So that's the usual traditional model, whereas the targeted model would look at mechanisms and then target that specific mechanism and then do an intervention. So this, if for people who are finding it difficult to follow, is similar to breaking the task into individual components and then treating each component as a separate task and then unifying it to form a behavioral goal. Now, a similar thought process, except that it's extended a little further into far more specific events and trying to understand very clear targets to change, which effectively cascades upwards to develop a behavioral intervention or a behavioral change in the body. So, how does this work? It We expect that target thinking improves clinical practice with respect to assessment, with respect to clinical reasoning, with respect to intervention selection, and with respect to outcomes measurement. So we would have an assessment target, which could be either a radiological, a physiological, or a biochemical target for assessment, and we would have a reasoning target. So let's say, for example, we're discussing stroke. So our assessment target would be, for example, a particular aspect of tone, for example, say spasticity, say a further detail on spasticity that says activation patterns, a further discussion on activation pattern that says excitability. And in clinic, and then that excitability assessment would give us clinical reasoning as to why a given inhibitory excitatory target needs to be addressed. And then we select an intervention that modulates excitability of a neural network, and then help that cascade to move upwards until it moves into a behavioral task, such as, for example, movement of a hand or forming a function, etc. The same thing would follow to become an outcomes measurement, where we would try and assess outcomes uh, of a given intervention as a function cascade, both at the level of the target as well as at the level of the behavior. So, with this in mind, uh, we try to infer possible neural mechanisms in target thinking and potential system dysfunction in target thinking. So, for example, we start at slow gate example and a potential uh, as a neural mechanism, and a neuromuscular output limitation would be a potential system dysfunction or a potential limitation. So, how does target thinking work? The target thinking works with observable impairment. So we go through the usual framework, the ICF frameworks, and extends it instead of 5 levels into about 8 levels. And we don't have to go through all the 8 levels. We just can stop at the 4, and then the rest automatically cascades itself as a part of the treatment event. So we start with observable impairment, and then we follow through to an underlying neural mechanism, and based on that underlying neural mechanism we start an appropriate intervention. So intervention selection can be chosen to influence very specific examples. For example, strength training is uh, towards neuromuscular output, and cueing is towards motor timing systems. So essentially, what I'm trying to convey is that each time we try to pick up a clinical reasoning event where we look at an underlying causal mechanism and then choose an appropriate intervention. The intervention is chosen to influence very specific mechanisms rather than uh, a gross behavioral intervention. So the actual word is to be, or the targeted information is specificity of mechanism. So if strength training is a focus, then the neuromuscular output translates to firing of fibers, and fiber becomes your primary target, that, or maybe fiber plasticity becomes the primary target that gives you the strength that you are required to. So that particular component is the one that we will understand as a full loop or a closed loop system, which we will discuss a little later. So in the same way, if motor timing systems are the analog of neuromuscular output, say for example in a patient of Parkinson's disease, then cueing is a behavioral intervention, but the cueing happens to a motor system, but we don't stop at the motor system. We move on to understanding basal ganglial circuits, for example, and then from BG move on to a very specific network that we can understand. And from there on, we take that all the way back to the cueing mechanism that started it all. So if targets in pharmacology happens to become I'm sorry about this one. The pharmacological targets happen to be receptors, enzymes, and molecular signaling pathways. And these usually operate at the molecular scale, whereas, excuse me for a second. Yeah. Whereas our frameworks happen to work at a functional outcomes or at a physiological level. So we operate slightly differently when compared to pharmacology, where instead of molecules, we focus on function and physiological changes. So to so now, what is the challenges that we see in these kind of target thinking? The challenges usually are that our nervous systems having distributed mechanisms, there's a lot of overlap. So for example, timing circuits in the brain cannot be very easily interrogated, because timing circuit in itself are subservient to neuronal firing mechanisms, which in turn is subservient to neuro transmitter mechanisms, which move into biology or physiochemical events. So, because of such cascade informations, for us, target thinking is actually a little bit of a challenge. Second, or the in is behavioral complexity. Behavioral complexity is a emergent component where, for example, if 10 muscles of the upper limb would contract, then it the total emergent event is a complex behavior that cannot be explained with any one muscle in any given situation. Now, this is different from what we usually see in pharmacological systems, where we say that, all right, let us say that the patient has, say, hypothermia or hypothermia, and then you give medication, say, for example, crocin or paracetamol, and only the thermal behavior is changed, or somebody has a slightly higher blood sugar level, then you give a hypoglycemic to reduce only the blood sugar level. So these things are easier in the pharmaceutical terms, because we don't it doesn't cascade to behavioral complexity, whereas in our field, any change automatically cascades to behavioral complexity. This is both a positive and a negative thing. The positive thing being, if we focus at the right kind of targets, the, the upward cascade to behavior is automatic. On the other hand, if the connection or the relationship between behavior and targets are too complicated, it becomes very difficult to control the upward cascade of behavior. So, usually, targets in neurorehabilitation should typically be distributed, it should be network based, it should be dynamic, and it should be activity dependent, because usually recovery comes in as a part of all these three put together, and it's a combination of biochemical versus or physiochemical and behavioral components together. So when we discuss target types, for example, uh, our target types in our field, we have pharmacology, which is a molecular target. In surgery, we have a structural target. And in neurorehabilitation, we have a dynamic or a system dynamic target. So in this particular context, I offer four target therapeutic domains that seem to be relevant in the field of neurorehabilitation. The first target that we have to focus on seems to be synaptic plasticity. So we need to think about synaptic plasticity when we discuss an assessment or management. Second, it seems to be network excitability. Third, organization of circuits. And four, is neuromuscular outputs. These four seems to be targets, one at a biological level, one at a physiological level, one at a systems level, and one at the level of the organism. So at these four levels, each time we discuss a particular intervention, we would look for it and try to target these four domains. So let me go across each one in a little bit abridged version. So for example, for synaptic plasticity, we understand that mechanisms include long-term potentiation, synaptic strengthening, and experience-dependent plasticity. So these three things should be the target for any assessment or intervention. So when we discuss research or clinical reasoning focusing on a given condition, we would look at long-term potentiation or long-term like potentiation, LTDs, or synaptic strengthening, similar to what Hebbian mechanisms would suggest, and experience dependent plasticity, similar to what happens in, for example, CIMT based intervention. Now, instead of trying to change a behavioral intervention, my viewpoint, if you will, is to focus on each of these individual, because not every subject would have all these three as a primary target. The next is network excitability. So network excitability as mechanisms include excitatory inhibitory balances. You will see these kind of events in, for example, Parkinsonian conditions, though we don't speak of excitatory inhibitory balance as a target. So if, for example, a patient has early Parkinson's and is not on levodopa, for example, he might have this excitatory inhibitory balance that can be observed, established, and then targeted individually, which causes an upward cascade that automatically releases the kind of rigidity that we force in target. On the other hand, we could, for example, in contrast to the current behavior where we would go through to get the same outcomes, but try intervening in a very complex behavioral manner. So the second is corticospinal excitability. So corticospinal excitability is a component that is commonly seen, for example, in stroke and other corticospinal disorders, for example. So we know, for example, in a lot of cases, irrespective of where the stroke is, the excitability of the cortex drops significantly. The same thing happens with pathological synchronization mechanisms, where suddenly the neurons across the nervous system synchronize, and that causes problems, which usually happens in athetoids and ataxias and other events, where the right and the left cerebellar hemisphere synchronize when they shouldn't be. So this becomes a target for us to focus on, and that helps us to figure out in layman terms what's happening to the system. Third, of course, is circuit organizations. Uh, the common ones are cortical remapping, and connectivity changes and sensory motor integrations. So they are slightly higher level targets to work on, because we don't work on any individual event. We know, for example, that very strong sensory inputs are quite competent in cortical remapping, seen as such as phantom pains and phantom limb syndromes and so on and so forth. So this is a higher level target. And at last, we have motor neuromuscular output, which becomes the end effector organ in many of the theories of motor control and learning, and where we focus on recruitment patterns and activation patterns, force generation, muscle disinhibition metrics, and so on and so forth, which focuses on an end effector level. Obviously, any one target isn't enough, but multi-target, multi-system involvement is common amongst us. And my suggestion essentially seems is to be that if we were to divide targets, focus on them, we may have better outcomes. and better control of outcomes rather than just say better outcomes, and be able to personalize interventions a little better. So clinical manifestations such as, for example, spasticity, are not really the same as network excitability. And poor coordination, for example, is an emergent property of circuit organization, so is spasticity. So instead of trying to understand its like spasticity, uh, we are trying to understand it with means of their subservient substrates or subservient networks. So we are discussing clinical manifestations versus targets. So what makes targeted therapy? A therapy, we can say, is targeted when it identifies the underlying mechanism, selects an intervention that is aligned with and focused on that mechanism, and produces a measurable change in the target. So, when we discuss traditional rehabilitation frameworks such as BOBAT, PNF, motor learning, CIMT, these were therapies that were largely developed from clinical observation rather than explicit targeting. And so the interventions are usually at a level of a human behavior rather than at a level of a neural substrate or anything above a neural substrate. So now, as we transition to technology, how does this change? So technology tends to help us with additional possibilities. We have a two level framework. Technology, the way I look at it, is physio or physical in nature. So I believe technology will supercharge physiotherapy the same way biochemistry and radiology supercharge medicine. So, because biochemistry gave biochemical insights which developed drug and targeted drug therapies. And I believe technology will give us the physiochemical insights that we believe can focus towards targeted physical therapy interventions. So that I believe and in one line, the role of technology. So why does it matter in today's world? You will see that consequent speakers would take this in a much more deeper manner. Technology enables us, as of today, objective measurement. It helps us to interrogate the physiology of our human body, which is the level at which physiotherapists usually work on. And biochemical nature of the human body doesn't give us as much actionable info as interrogation of the physiology of the human body. It helps us to target, modulate a live tissue, which is right up the alley of physiotherapists. This is exactly what we are meant to do, and therefore, any improvements in technology, I would believe, would translate to improvement in physiotherapeutic or neurorehabilitative outcomes. So usually when we discuss outcomes, so conventional rehab assessment often relies on observation, uh, rating scales, paper-based measures, which work at the level of the organism or at the level of behavior rather than at the level of the underlying neural processes or at the level of the neural substrate. And I'm not trying to say that these are not useful or shouldn't be used or in any other connotation. I'm trying to impress upon that technology helps us to go deeper in. So, as a measurement tool, we know that we can use quantitative assessments uh, in terms of movement and in terms of physiology. So, we could, for example, use movement analysis to pick up elements of movement or substrates of movement rather than just movements itself. So, we know that it's in a patient with Parkinson's, it's not about the movement itself, it's about the accelerations of the limb during swing phase that are critical to understand whether a given a patient is going to improve or does not improve. We know that with movement analysis, we can titre doses of Syndopa much better than pure clinical assessment, because if we were to look at the way the gait progresses, for example, on a force mat or on a movement platform or on a motion capture analysis, we could actually titre doses saying that DOPA has reached a given limb and is effective at this particular event or not. This kind of insights helps us to monitor, not just monitor actually, but to tailor interventions to get specific outcomes of these. Wearable sensors, for example, are giving us fantastic measurements, though it's a little early to give a Nobel Prize to somebody who's developing wearable sensors, but it will eventually get there where it starts to add absolute value to neurorehabilitation outcomes. As a feedback system, we know that we could use, for example, biofeedback, auditory feedback, visual feedback system. These systems, for example, are fantastic in developing structures or sensory enrichment structures or alterations in motor firing mechanisms at the level of the neural output or synaptic ability. We know, for example, we could put an EEG headset on the person and focus on developing a very specific intervention, and feedback and change reasonably complex events such as, for example, the autonomic nervous system or fear modulation and such. So let me just take you through a very quick understanding of, for example, a fear system. Here you will see that we are looking at a skin conductance and temperature assessment, where we are actually trying to see if the patient has a fear or an apprehension of fall. On the orange area, you will see that the patient was made to sit, and all the vertical lines, this is part of one of our postgraduate projects, you have these dots that say this is where the autonomic nervous system excitation is, and as the patient comes more near uh, towards a movement, for example, in this case the target is for the patient to be able to increase, uh, one second. Yeah. So the patient has been asked to slowly get up and move towards an obstacle, and then the patient is expected to cross the obstacle. So you'll see the red line here is the point at which the patient is expected to cross the obstacle. Now the patient is contemplating, and as the patient contemplates an obstacle and the ability to cross, it's not very obvious here in the orange line here, but if you can notice the spike in ENS activity just before she actually takes the step, it gives us very good insights as to what exactly is happening in the mind of the patient. And that, I believe, is targeted rehabilitation, where we are not targeting behavior at just the behavioral construct, but we are going deeper to understand that right at the moment you have this maximum spike that happens. And this is before the movement happens and not really after the movement happens. So this then becomes an underlying substrate which we can use to target therapy. So that's technology as a biofeedback system. So here in this case, it was skin conductance or ANS feedback, but you also have visual, you also have auditory and other systems as feedback. So feedback systems allow patients to observe physiological signals. We could pick up muscle activation, joint motion, force output, or in this case, ANS input, and we feedback into the system and we can regulate the ANS. Now, if we regulate the ANS, then fear is modulated, not at simply the behavioral level, but at the ANS level. And the cascade automatically, that is very unique to us actually. I don't think pharmacotherapy can claim that the upward cascade is near perfect and we get a behavioral outcome. Though it's not an absolute rule, but on an average, I believe that it follows this upward cascade rule quite well. The other things that we could focus on that is more targeted, you would say, in terms of therapy is functional electrical stimulation. So in this case, for example, we could use stimulation to focus on the neuromuscular output. You could focus on alteration of systems. In this case, the subject you see is a quadriplegic. So we have electrodes on the muscles of the leg in this case, as well as the muscles of the trunk. Now, the muscles of the trunk are trigger muscles that tells the nervous system down below what exactly the legs need to do. So we understand central pattern generators in the nervous system. We also understand the central pattern generators usually have sensory triggers or motor triggers or kinesthetic triggers. So if we pick up the trigger muscle in a remote place, we can actually target the CPG that was driving the muscle down below. And that is very interesting to understand and implement. So we use gait assistance. For example, in this case, the patient is walking, and then you will see that the stimulator is working only at about 1.1 second or so of the system. And the rest of the times, the patient is encouraged to do the movement automatically. And this ensures that the patient's gait's improved. But at the same time, it gives us this ability to focus that first half of the gait stride, we will do active assistance, and the second half, we will do passive assistance. So the stimulator would activate the muscle from heel strike to heel off, and from here, this is the patient continuing the therapy. So in one gait stride, you could do both active assisted and active, if you will. Though it's not a very good analog to understand it, but we would say that in one sense we give sensory input, in another one we give motor input or assistance, and hoping that this will cause motor relearning to fire. So the next one, of course, is brain-computer interfaces, which is a relatively new kid on the block. So BCI systems usually detect nervous signals and translate them back to control for rehabilitation systems. So in this case, BCI is mostly used to understand whether a given area of the brain can be activated enough to trigger a cascade downwards. Now, since the patient's not able to appreciate that very, very well, BCI systems help us to do it. I will not delve into it deeper because future speakers are going to delve into that. So essentially, I would now start to surmise my presentation. Different technologies influence different therapeutic targets. For example, we could use biofeedback to target motor control and learning. We could use FES for neuromuscular output, and we could use BCI for cortical activity and cortical mapping. So essentially, we are moving towards targeted rehabilitation or closed loop rehabilitation, where we don't give behavioral inputs and wait for outcomes to happen. We follow the loop, if you will, through and through, and develop sensing, computation, and feedback. So these systems enable adaptive therapy or personalized therapy, and which is by far the most interesting development, I believe, of the decade, where we have both knowledge of results and performance at absolutely our fingertips, and that makes for a change. So to summarize, I would want to propose that neurorehabilitation targets neural systems rather than molecules, but at the same time, this kind of thinking improves clinical reasoning, and we could in today's world use technology to enable both measurement and modulation of the neural processes. And targeted neurorehabilitation represents a convergence of neuroscience, technology, and rehabilitation. I guess with that, I thank the organizers for time. I thank all of you for listening to me patiently. And if there's any questions and if my time still allows it, I'll be happy to take it forward from. Thank you. Dr. Uttara, I hand over it to you.
There are a few questions we'd like to take your inputs for.
Yes,
The
please.
first question, which are the most promising technologies currently being used in post-stroke motor recovery?
Uh, mm, I think quite a few. The one that holds the most promise is exoskeleton. That is holding the most promise, though the promise has not been realized by a very large margin. But that seems very interesting. The next big one, that this is really big, in my opinion, is the neuromodulation therapies, transcranial direct stimulations, and such. They're they seem to have massive potential. They're very promising in nature. Neuromodulation hasn't been touched by neuro rehabilitation specialists. It's in the field of alternative medicine in some sense, but not been touched very well. The evidence is slowly building up. It's not there yet, but it's very promising. I would say these two are big. I'm not saying there aren't others, but to me, these two sounds pretty much interesting. Dr. Uttara, you are muted.
Are you able to hear me now?
Yes.
So, what are the barriers that physiotherapists face when adapting these tech-based rehab tools in the clinical practice?
Once again, I think there are two things that I would say. The first, of course, is money. Technology is usually at the moment a little expensive, though it is becoming cheaper by the day. The second barrier is mostly attitude. So we have been trained to think about for some reason not using too many tools. We would like to think of our hands as tool concept. I'm not trying to say that it's wrong to think of hands as tools, but somewhere along the way we've become a little tool averse. So we don't seem to be very happy to use tools anymore because we would like to show that I don't need a tool to generate an outcome. So this seems to be some kind of a prevalent behavior. I think it's time to come out of it. And that is a common barrier. So if somebody were to tell you that I'll give you in a tug score, I'll give you distributed tug scores, that I'll tell you how much time it takes for a person to sit or stand. Usually that doesn't evoke a very positive response because it's, how does it matter any which way? Because my task is functional. So these are the two primary barriers that I perceive. I'm sure there are a few other things that we could discuss. Dr. Uttara.
Since many neural systems contribute to recovery, how do we avoid focusing too much on just one target during rehabilitation?
Good question. I think that's a very good question. Uh, well, when we try targeted physiotherapeutic techniques, that is a common pitfall to have. We could over focus on one thing. Now, the objective of targeted clinical reasoning is to ensure that we target underlying mechanisms. the threat is real. We could go too deep and get into a rabbit hole where we can't come out of, and in the end we change an outcome without changing behavior. That's not acceptable. It's not a simple answer, I would say, but usually a good targeted thinking would go from behavior to substrate. And so you should always have a 30,000 feet view of your patient. And that's really important. We cannot lose, as they say, baby for the bathwater. As good as targeted interventions are, and as good as hitting a neural substrate is, because it's a foundational, fundamental truth, you could get a little bogged down, and you could get deviated. I get that. You should always have a 360-degree or a 30,000 feet sky view of these events. And it's imperative that we have it. That's one way to uh, not get into that, I'd say. Dr. Uttara.
Are there any cost-effective tech solutions suitable for resource-limited settings?
Well, the nice thing about technology is it gets cheaper by the day. Whereas, I don't know, maybe pharmacotherapy gets costlier by the day. So by the definition, for example, I don't know, the speaker that I'm talking with, or the monitor, which used to cost 50,000, now is 15,000. So by definition, technology becomes cheap. So if you're an early adopter, you are likely to pay a little bit of a premium. But if you wait long enough, it becomes very cheap, and it's happening. Some of the interventions, for example, motion capture costs about 1.5 crores. It used to be 4 crores, now it's 1.5 crores. But in another 5 years, you have motion capture systems, different kind, maybe sensor based, which drop down to a few thousands. So by nature, technology is going to become cheaper. That's the nature of technology. We don't have to worry about that. But it's a positive point to think in that way, that eventually it's going to become cheap. Dr. Uttara.
Are there any certified programs or workshops you recommend for physiotherapists to learn applying technology in neuro rehab?
I haven't seen any specific ones, I would say, though there are plenty of things like AI in medical sciences and such. Though nothing has been directly targeted with physiotherapy as a target audience, unfortunately, I don't know of any. Dr. Uttara.
How can we tailor the rehab plans for patients with cognitive impairments?
Okay. So cognitive impairments are complex impairments by nature because it's a meta impairment. The word cognitive impairment, we cannot always connect to a neural substrate. So it's a tough question. In that case, the way we would approach the problem is at the systems level rather than at the molecular or the biological level. At the systems level, we are looking at it perhaps as a as a mechanism rather than that of as a pure neural substrate. So, for example, we know that a lot of dementia, for example, is due to reduced power over the parietal lobes, right? And we know that. It means that there is a combination of circuit uh, dynamics as well as cortical excitability. So we also know, for example, that regional transcranial magnetic stimulations uh, can improve both circuit, it can increase coherence between hemispheres, for example, as well as modulate cortical excitability mechanisms. And it's a very common therapeutic target where we use RTMS towards such interventions. Another common cognitive uh, or metacognitive event is depression or stroke related depression, where you could use these kind of events to alter cortical excitability and synaptic excitability and alter circuit dynamics and change interventions. I hope it answers the question, if I've understood it correctly, Dr. Uttara.
We'll take one last question. What is the difference between high intensity training as proposed by ANPT versus the targeted therapies?
Can you please repeat as supposed by? I didn't get that.
As proposed by ANPT therapies and the targeted therapies.
Okay. So this isn't about choosing a different intervention or a like high intensity therapy uh, targets what I am trying to put forward, and the difference essentially, if there is if I have to answer it in the same context, the difference is that high intensity therapies would target multiple targets. It's like carpet bombing versus a surgical strike. I don't know if that's a good analogy in today's world, but yeah, a high intensity changes multiple things, and you don't really have control on all the targets, or we don't even think too hard about targets because we expect that the human organism or a behavioral change would choose the appropriate change, and the body would choose the appropriate change and adapt. And that's how all these strong therapies like HITT and all these kind of things work. We are looking at a more focused targeted model. So you would, for example, go straight to a given muscle that triggers the cascade and then focus on that, and then maybe cascade upwards all the way to a HITT, knowing that you are targeting four different systems. That's all. It's an attitude change, or it's a change in viewpoint or a vantage point change, rather than changing the intervention itself. It's just a different, I'm not saying it's just a different, it's just that we use the same therapies perhaps, but we focus on different things, or maybe divide it and focus and such. Dr. Uttara. Dr. Uttara. uh, Dr. Uttara, are you there? I'm unable to. Dr. Uttara Mohan, are you there?
I think she is having some
Sure.
connectivity problem.
All right.
Are you able to hear me now?
Yes, doctor. I am.
Thank you, Dr. Ramesh, for sharing your knowledge and valuable inputs. Uh, Now we'll go ahead with the second speaker presentation.
Thank you. I'll be muting my screen.
So, Dr. Ramesh, I request you to close the screen sharing so we can have the next person be able to present. So I've been having a bit of technical issue. I hope you are able to hear me now.
Yeah.
Yes.
So our next speaker for today is Dr. Tarun Lala. Uh, I would like to introduce him. He is the Zonal Head of Physiotherapy and Rehabilitation at Max Super Specialty Hospital, Saket, BLK Max Dwarka, with over 24 years of experience in clinical rehabilitation in different multi-specialty hospitals in Delhi. He has completed his MBT in neurology and is certified NDT therapist from US and trained in gait and motion analysis from Rome. He has been part of numerous national and international clinical trials on assistive technology in rehabilitation and serves as a honorable rehab advisor to the Indian Head Injury Foundation. He is actively engaged in Delhi IIP Anti-Quackery Committee and holds membership in various prestigious bodies, including World Federation of Neurorehabilitation, World Stroke Organization, European Stroke Organization. His leadership and contributions continue to advance neurorehabilitation practice. He will be presenting on the topic Role of Advanced Robotics in Neurorehabilitation, Evidence-Based Practice.
Thank you, Dr. Uttara. Should I share?
Yes, you can share.
Yeah. Thank you so much for the such an elaborate introduction. And I want to congratulate the IAP body and especially the neurology subgroup headed by our esteemed president, Dr. Jha, Dr. Ruchi Vashne, and the others. And of course, thank you so much for moderating the session for us today, Dr. Uttara. So let me share my slide. Is my slide visible?
Yes.
Can I start?
Yes, you can start.
Yeah. So hi everyone. I'm Tarun. So I'm going to talk about role of advanced robotics in neurorehabilitation, and basically it's an evidence-based approach that we do. So I think she's already spoken about me, so I won't waste time in that. So just a brief introduction. What is neuro rehab? I think Ramesh sir has already elaborated a lot about it. So for this is especially for the upcoming young budding therapist. So you have a team. So neuro rehab is a umbrella under which physiotherapist is one part of it, and there are other colleagues that you would have. Especially the medical fraternity, starting with a neurosurgeon, neurophysician, neurocardiophysiotherapist, occupational therapist, speech dysphagia therapist, very important, psychologist, there would be a nurse in the hospital or outside at home, orthotics, and a social worker. So, when we talk so much about neuroplasticity, let me tell you all, the crux of a neuro rehab is the neuroplasticity. We've heard this term so many times. I think just now people must be hearing to Dr. Ramesh. He also spoke about it in an elaborated way. So I would like to say, this is the ability of the brain to change its structure or function in response to the experience. So let me tell you all, when a patient comes to you in your clinic or to your OPD, many a times the patient would turn up after a year, 6 months, and you would hear that from them, like my doctor told me that after 3 months you would not improve, or after 6 months you may not improve. So let me tell you, the good news is, I have personally seen patients improving even after 4 to 5 years of stroke. A person who had stroke 5 years back, if he's not given a proper therapy, and he turns up to your clinic or to your center, believe me, if a therapy is done properly, what we were just discussing, a targeted neuro rehab, you will see wonders in that patient. So brain is the only organ in the body which can actually give you the results, no matter what. But it has to be very targeted therapy. When you say the capacity of the nervous system for adaptation or regeneration after trauma, ability of the central nervous system to undergo structural or functional changes in response to new experiences. So this is the line that you should remember, is the ability of the central nervous system and the brain to undergo structural and functional changes. But that all depends what kind of therapy you are giving to the patient exactly. Like in previous talk also, he spoke little bit about experience based plasticity. The plasticity is varied into different types. One is experience independent plasticity. This is very prenatal. When you are taking birth, there is already a plasticity in you, and as you grow, the plasticity is evolving. So that is called the experience expectant plasticity. And as an adult, what experiences you have behind you, and the why we say, like, brain has those forgotten functions when the person suffers a stroke or any neurological insult to the brain. But you still have that dependent plasticity which was there, and that is the area that you have to tap as a therapist, as a rehab therapist. It can be an occupational therapist, physiotherapist, speech therapist. That is the area that you have to target to get that plasticity driven from the patient. Remember, neurons that fire together, they wire together. This is very important line, and you would find this line in many of the textbooks. In fact, a lot of times when you are actually reading or somebody is teaching you, they would read this line again and again. Neurons that fire together, wire together. So brain can change at any time, at any age. So no matter what, the patients comes to you even after 3 years, 4 years, earlier the better. But even if they come after a long time, don't don't lose hope. In fact, give hope to the patient that they can further improve depending on the kind of injury they have to the brain. Now, briefly talking about type of functional robots we have. So robots is something, which have been there, in industrial robots. We've heard, before the rehab robots came in late 90s and early 2000. Before that you have those industrial robots. So all these robots were actually, derived from those robots that we were using. And then, slowly people started to understand the actual, functionality of these robots, and how these robots can actually, help in day-to-day function of the patient. If you talk about a hand robot system, it's a very, if you see this diagram here, the flow chart will actually show you the hand robotic system. There's a hardware, there are training paradigms, whatever you want to achieve from that robot. Your robot can be a simple passive movement robot, where you're just putting your hand and you're just moving it. It can be as simple as that, to an extent where you can actually, play games. You have sensors, you can transmit through EMG activators in your for your hand function, for your arm function. So, depending on the variability and the complexity of the robot, you can have that robot. So this, starting from the low cost to high cost robot, all depends what is the point that you want to achieve, what is the goal that you want to achieve. So, the cost also varies according to that. But yes, there are different type of robot that depends on the patterns of induction, detectable intentions, and of course the user feedback. What we call a buyer feedback is very important, while, whenever you're doing a hand robotic system, or a leg robotic system for that matter. These are few pictures I have, posted in the slides, just to show you what type of robots you have. There are different type of robots, and believe me, all of it is available in India, depending on the cost, from low cost to the high cost. These are orthotic devices. Many of us are already using it in our daily clinical practices, from a spring robot to a, self-activating robot, to a robots. Now you have those bionic limbs. So this is just a small video I would like to show. So this is there at my hospital. So this is, if you see, this is a hand robotic system, is an aluminum robot, and there's an EMG triggered. So this robotic system also had an EMG, so a simple robot which can be a passive movement robotic system, versus a system where you are actually, using an EMG guided. So whenever patient has some kind of a trigger while doing, these are especially the stroke patients where the problem is the hand function. So you have those EMG sensors attached to your arm, where the EMG sensor will actually take the flicker of the movement, and then it will translate into a movement of the hand. So believe me, the patients who are not able to move the arm, and when the sensor picks it up, and they can see the movement, and then there's a screen in front of you, you can do different type of gaming options, because to make sure that your therapy is not a monotonous therapy. That was the reason why all these robots were actually also developed, because manually you could do to an extent, you couldn't do beyond that, because of course of the fatigability by the therapist and by the patient both. So you had to develop such things, where you are actually motivating the patient through these robotic systems. Talking, if I take a step back, we've been doing this treadmill therapy, which is called partial body weight support system treadmills, which were before the robots actually came in. This was just to show you how demanding it was, where you'll have 2 3 therapists holding a patient to make you walk, and then you would use the treadmill. But every time you are doing it with the therapist, every time there's a different movement. The joints are moving at a different angle every time, which have been, which have also shown that there have been some injuries to the patient in terms of their ligaments in the knee, ankle, or injuries at the hip level while doing the therapies manually. So that's how these robots were actually started coming into existence. No statistically significant effect of treadmill training with or without body weight system was detected. This was one of the reviews that you would find. A lot of studies were done. Key points of meta-analysis were: quality of training is not always ensured, because every time the therapist is different, or the weight transferred is different, the power generated by the patient or by the therapist was different, still too demanding for the therapist, and still too few repetitions. So repetitions were very few. Let me tell you once again, to ensure that we kick in neuroplasticity for a patient with stroke, you need to ensure at least 2 to 3,000 of repetitions in 5 to 6 days in a week. So can you imagine a patient whom you are seeing, how many times have you done the repetitions for that day? But to set in a neuroplasticity, you have to have 2 to 3,000 of repetitions of that limb daily. So it can be inside the session or outside the sessions. That is why we always say the home program is also very important for these patients who come to you. Never leave them away without a home program. It is very important for them to do those repetitions with their caregivers or a therapist at home. Anything that would help to kick in the neuroplasticity. Talking about the lower limb robots, robot driven exoskeletal robots. So there are different types of robotic systems. One is the end effector robot, another is the exoskeletal robot. So I'll show you a couple of videos of both the robots that we have. So robotic gait orthotic combined with a harness supported body weight system used in a combination with the treadmill. The robotic device, according to a pre-programmed gait pattern, guides patients' legs. The process of gait training is automated. So this is an automatic robotic device. End effector, for that matter, it's an electromechanical solution with two driven foot plates where they're stimulating the gait phases. So all these robots are actually, mimicking the normal gait pattern that an individual will actually walk, because what happens after stroke, your gait pattern really goes haywire, and you don't know when do you strike the heel, because most of the patients, they have a foot drop. So they are walking with a flat foot, and the gait pattern, sometimes they have some spasticity, so there is a circumduction. So to avoid those things, manually it was not possible. So these robots came into existence. So when you say an end effector robot is, any of your limbs where the end distal limb is attached to any form of a robot, where it is the robot is moving the distal limb, is called an end effector robot. Prerequisites for robotic gait training: a comprehensive assessment is carried out to rule out all the necessary contraindications. It is very important to have a prerequisite before you take a patient to any robotic system. You have to avoid any vasovagal attack. So, there has to be some form of initial standing before you take the patient. So it can be by the way of doing tiltable standing or manual standing on a frame for at least 20 to 25 minutes before you can take the patient onto a robotic system, because once you tie, the donning and doffing itself takes 5 to 10 minutes. So if a patient goes into a vasovagal attack, you may not get that much of time to take off the patient from the robotic system. So you have to ensure that the patient is able to stand for some time before you take the patient on the robotic system. Consent is very important. This is for the therapist. It is very important to take consent from the family, or if you have a treating doctor who's attending to that patient, so that tomorrow there should not be any medical legal issues that you're running in. An initial trial run of 5 to 10 minutes is done to check for any discomfort or the adjustment is required. So these are the prerequisites for any robotics. So all many of my colleagues here and the young therapists would be wanting to have a robot in their clinics or in their hospital, but you should have all these check-in areas, check-in sheet before you start any robotic session. And thereafter the patient started with the session. Usually the first few sessions last for 20 to 25 minutes, and then the duration can be increased as per patient's tolerance. But to my experience, I think between 20 to 25 to 30 minutes, even maximum up to 40 minutes is more than enough for any robotic session, because you have attained the number of repetitions that you are requiring for that instance. For example, a robotic system with an end effector, you may have repetitions of around 800 to 1000 repetitions for that day. And I think that is more than enough to start with, and then slowly you can increase depending on the kind of resistance you want, or whatever you want to achieve. Indications are very simple. All of neurological conditions can be taken for the robotic system: stroke, spinal cord injury, multiple sclerosis, cerebral palsy, Parkinson's, TBI, and other conditions. Contraindications, I said: orthostatic circulation problems, unstable fractures, not consolidated fractures are very important. Severe patients with severe osteoporosis should be you can do it, but you have to be very careful. You need to have somebody who's experienced in that robotic system. Patient has to be cooperative. Mentally, patient has to be stable enough. A pregnant lady should be avoided. Severely fixed contractures, you have to be very, very careful, because at the end of it, we want to help the patient and not to make sure that the patient gets any kind of a damage or trauma while doing the therapy. Open skin lesions in the area of lower limb or the torso has to be taken care. Cardiac contraindications is very important, especially patients on pacemakers or who have low ejection fractions, less than 25 should not be, I would advise less than 25 should not be taken for a robotic system, because again, I'm telling you, once you put a patient on the robot, if there's any code blue issue which can arise, you may not have enough time to get the patient on a flat position. Severe vascular disorders of the lower limb, epileptic patients and others should be very careful. This is just a picture of the end effector robotic system that we have at Max. If you see, the patient has been toned, and if you can see here, the foot plates are down where the patient is actually tied on the foot plates. So there's no exoskeletal, which you'll find in Hokuma and Locomet. There is no exoskeletal. So that is why it is called an end effector. So the limbs are actually free. So limbs are actually resting on a foot plate, which are actually moving and then integrating with the surrounding area. That is why it is called the end effector. Rehabilitative determinants of walking robotic gait training: cognitive involvement, execution functions, visuospatial skills, memory, language. Top-down stimulation is very important. Repetition intensity is important. Precocity, task specificity is important. Motor control, cardiorespiratory efficiency is also being monitored. So it helps in participation, engagement, and performance feedback. There are various serious game feedbacks that can be given to the patient depending on the severity or the mental function, and it's a multi-sensory augmented feedback. All these helps to kick in the neuroplasticity, and walking and balance activity recover. That is the end result of all these systems. This is just, I just shown you in the picture how the end effector really helps. The end effector, the foot is resting on the foot plates. I'll show in the video. And then you trying to simulate a physiological muscle activation, or simulation a normal gait pattern, for that matter, for any patient with stroke especially. Benefits: more than 800 steps, like I said. So you can do for at least for 8 to 10 sessions. That makes it straight, you have done 8000 steps for that matter. And like I said, to kick in neuroplasticity, you have your enough repetitions for that matter. So this is I'm talking about the leg robotic system. Specific repetitive practice of floor walking, stairs climbing, customizable movements which can be done with a gait cycle. Full control over gait variables. So while doing robotics, the therapist has his full control of the step length, cadence, dynamic body weight system, hip facilitation, and everything. And there are different modes. called the passive, active assisted therapy modes. A patient who comes to you initially has a little flaccid limbs. There you would like to do some passive activation and then slowly get into active assisted, active, and then also in resistant mode. Advantages of robotic gait trainer: key benefits: strengthens the muscles and bone, preventing muscle atrophy, offers a realistic simulation, allows isolating and generating specific phase of walking cycle, helps relearn stair ascending and descending, allows patient to enhance mobility and independence in daily living. Edge over other technologies: improves clinical outcomes, is less time, because you get the more repetition at a very less time, and in a very precise manner. Improves walking pattern and pace, better safety and comfort, reducing the risk of patient and clinicians injury as well. Adjustable assistance levels, upgrading the intensity as per tolerance. Again, there are other advantages with adjustable settings such as cadence. Like I said, the therapist has full control over whatever he wants to achieve. He wants to change the step length, he wants to change the cadence, and whatever step number of steps, everything, you have your full control over the system. Stair climbing is another advantage of these end effector robotic systems. And you just need one therapist to operate. You can quantify the progress. Everything is shown. I'll show you on one of those videos. Benefit for the therapist is short setup times. You don't need too much time. Open access to patients and control over gait settings and repetition at ease. Challenge, of course, is the cost, what Dr. Ramesh also mentioned. But good news is their local prototypes are being tested at various IITs, especially IIT Delhi and IIT Madras. I think, and I'm sure there's some promising results coming up. There are many devices which are now already available, at a market in terms of upper limb devices and certain prototypes in the lower limb. But then, once we have complete precision, which has to be 100%, I'm sure these low cost robotic devices will be available in the market. Conventional therapies, I will not talk too much about it, because we already have mentioned this. A lot of conventional therapies which we've been doing before, and a lot of evidences in terms of various publications which have shown very truly that patients who receive robot assisted devices for gait training in combination with physiotherapy after stroke had the higher chance to reach independent walking. So this is from the from our Cochrane collaboration, from the Cochrane review, which had actually shown very truly that robotic with the therapist. And let me tell you, so it's not just about robotic, it's also the therapy that you're doing apart from that, your limb physiotherapy, your manual physiotherapy apart. So all this in combination with the robotics system has shown that the patient has a higher degree chances of improving faster and in a much better way. Most of the robots are based on the prior idea that walking is an automatic subcortical ability. So this is what is being triggered while doing the robotic training for those, because you are actually making sure that the biomechanical point of the view, by reviewing the role of the trunk for a passive to an active activator, is being used while doing this robotic system. Bottom-up approach has been integrated in a top-down approach with a conventional use from a neuromechanical point of view, in which structures and functions are strictly connected around the specific harmonic point of equilibrium that maximize the efficiency of walking. This is just to show you how two separate groups were made, and we saw end effector versus conventional. End effector definitely has much higher incidence in terms of recovery, and all this could have been shown through the objectivity. There have been various trials before which have shown that a robotic system along with the conventional physiotherapy has been a much better, faster way of recovery. This is again just to show you how you can do from a conventional to a robotic system. A conventional by a therapist moving a patient with stroke could only achieve 50 to 100 steps, whereas while doing the robotics at the same time, and even in fact at the lesser time, you could actually do 1200 to 2000 steps. So robotic gait trainer is equipped with the force sensors that register the amount of robot generated force, assisting the patient to flow from a predefined walking pattern, allows delivering continuous support for the legs in a physiological walk pattern. high repetition accuracy and prolonged training duration compared to manual walking was able to achieve. The patient has to wear a robust shoes like James therapeutic shoes while doing the robot. There are different modes called the active modes, active assisted, and of course the passive mode is always there, but from an active assist to an active mode to a resistive mode. So you have different modes in these end effector robotic systems. We did a study for around 110 patients with stroke at max, in which stroke patients were 95. There was some pre-existing abnormality of the patient. There were 15 patients who were excluded and which we couldn't take them for the robotic system. But average session, believe me, after 15 sessions, that is an average. Some could do 12 sessions. Many of them could do more than 15 sessions, but we saw a tremendous change. And like I said, the average session duration was just 25 minutes, and we could see a tremendous change in their modified river-made mobility index and functional independent measures. There are other objective measures that you could also use. If you're talking about the upper limb robots, I would suggest to do a Figelmare assessment for the upper limb, upper extremity. But if you're going for the lower limb, to my experience, I think FIM is a very vastly defined objectivity that you can help, and you can see. These are the screens that you do when you do the robotic gait training. You can see these, they are predefined protocols in the system. You can change accordingly what you want for a stroke patients. There are sensors in the foot. You can see those sensors, how they feature while the patient is actually doing the weight bearing. So a patient with a stroke will not show a good weight bearing on his stroke area. So that is how the robotic system changes its. And also visual feedback, visual scenario. The patient feels as if patient is walking in a place of a wood, or on a seashore. So you have different different videos. We can actually help to motivate these patients. This is just to show you one of the patients. If you see here, this is a robotic system. Like I showed, this patient is walking on a robotic system, patient with a stroke. This was after, I think, after 2 weeks of robotic system. Now you could see the patient was actually able to hold this robotic system and is able to walk very freely on a robotic system. So this is a robot. If you see in front of him is a screen which is also showing the amount of weight bearing on the foot. If you see here, the blotting happening on the foot area. So this is you can actually see very easily. Another video, a therapist is using a therapist is using so this patient had some instability with his knees. So he was a case of again, he was a neurological case. And if you see here, we have tied some knee gaiters because there was some instability. So these kind of patients, then you have to, when you are using an end effector robot, then you have to see, because the knee is free. So some patients may not be able to hold the leg properly. So there you have to do some kind of innovative techniques how you can help these patients. Just again once for all of you. All right. So now, just to show a video what we have at Max, this is exoskeletal robot. Okay. This is exoskeletal where this is on ground robotic system. So the therapist has a full control of the patient. Patient is actually on a gait trainer. If you see, patient is on a gait trainer. He's a patient with stroke. So slowly this device, the harness will go off, and the patient will be able to actually walk on ground gradually. So initially patient is given this exoskeletal. If you see here, the patient is with the exoskeletal. The therapist behind is controlling, and then slowly after 3 weeks of program, you could actually move the harness from there, and actually the patient can actually do a ground training using the elbow crutches or a stick or a walker within that initially, and slowly. So there is a difference between exoskeletal and what I showed you, end effector robotic systems. And robotic systems are mainly on the treadmill training, but this exoskeletal, which is now becoming more of coming into the market, with the ease of the function, less space occupying robotic system. And of course you can do an on ground training. A patient would actually love to do an on ground training rather than on a treadmill training. So few of the outcome measures that we use in our facility, like I showed, modified functional ambulation, modified river made, Berg balance score, Barthel index, and there are various other outcome measures that you can use. Functional independence measure, very widely used by us, and I'm sure it's been used all across our fraternity. Fugel assessment for upper extremity is very important if you're doing a case with the upper limb robotic systems. So these scales measure ambulation, mobility, balance, and activities of daily living. FMA for upper limb function. This is just to show you what scales we are using. These are available in Google or in whatever books. If the students are there who can get on hold on those books, especially for the neuro rehab, you have these scales readily available, and all of them are free to use. Most of them are free to use. I personally like this functional independence measure. The reason being, it covers the comprehensive aspects of the patient, to check his functions of daily living. Very easily done. It may not take too long. It hardly takes 20 to 30 minutes to do this FIM score. So I would suggest and request all the therapists to use FIM score as an outcome measure, which can be done at the initial level and then subsequently after 2 or 3 weeks of program. Thank you so much. These are a few references. Thank you.
Thank you, Dr.
Over to
Tarun.
Dr. Uttara. Thank you. Stop sharing.
Yeah, you can stop sharing. Thank you, Dr. Tarun, for the fantastic session on the future of robotic neuro rehab.
Thank you.
There are few questions posted. So let me ask one by one. First question is, which neurological conditions, according to you, stroke, spinal cord injury, or any other neurological condition, see the highest rate of functional recovery when robotics are introduced compared to traditional manual therapy?
Yeah, that's a very good question. To my experience, I think now I've been using this robot for almost a decade. I think we were one of the first to use in North India. So to my experience, stroke has shown tremendous, improvement in terms of robotics. And after stroke, I would say incomplete spinal cord injury patients. But let me again tell you, incomplete spinal cord injury patients, a lot of institutes and clinics, they are promising results to patients who have complete transaction. I think that is more of a motivational therapy than actually patient recovering. But to my experience, I think stroke and incomplete spinal cord injuries really help. And of course, you can use it for patients with Parkinson's and multiple sclerosis for that matter.
In post-stroke rehabilitation, which helps in better recovery, functional rehabilitation or robotic rehabilitation?
That's again a very good question. When you say functional, the term functional itself tells you the patient has to do some kind of function. So they actually came into existence because like I said, to trigger a neuroplasticity, you need certain number of repetitions, which has been proved also through many evidence scientific papers, that you need at least 2,000 to 3,000 repetitions in a week, which is humanly not possible. So like I showed in one of my slide, manually you could train a person, you can do some task approach, but how much can you do initially? If a patient is in a flaccid state, you can't do too much with that patient. So that is how these robotics came into existence. They could do multiple repetitions. That again, I would say, in my experience, I would say target therapy is the dose that you want to give to that patient, and the frequency of repetitions that you want to give to that patient. That is very important. And ultimately, everything comes in as a functional or a task based approach. So this is nothing that you have to do something, robot is separately from a functional, it is integrated with the functional approach.
How does the robots assist as needed software specifically trigger neuroplasticity rather than allowing the patient to become passive during the movement?
So again, my answer is the same what I spoke in my previous question. How do you trigger a neuroplasticity? I'm telling you, believe me, if your institute can afford a simple robot, where a therapist can actually do 1,000 to 2,000 repetitions in 20 to 30 minutes. That would trigger your plasticity much faster, much easier, and in a much precise manner than a conventional therapy where you are actually two people are holding you and assisting you to walk. Of course, robot is for the initial phase. I'm telling you, once the patient is able to walk a little bit, then I would always tell you not to use robot, because then you have to get into your natural environment. Yes, initially on robot you can be passive, but once you achieve an active assisted movement, then you don't need a robot. Then you need a functional therapy on ground training, while we are using other techniques like NDT, MRP. That has a main focus after that. So robot is more of an initial or sub initial phase.
Okay. Another question, very interesting one. In the context of robotic assisted stroke rehab, what are the clinical considerations regarding hypertonia and the velocity dependent stretch reflex?
Yeah.
And there is an extension to that question. Does evidence-based practice support the initiation of robotic protocols from day one without risking the development of spastic synergies?
Very good question. The question was in two parts. Let me
Yes.
answer the first part, the spasticity, what you spoke about. Let me tell you, as a physical therapist, it is very important for you when and where and how much. Again, I'm saying, when I say to my language, if I say target, I'm targeting a particular limb. Now, if I want to use robotic for the lower limb, for that matter, if patient is in hypertonia, I would not use a robot initially. I would first do my conventional therapy. I may send a patient to the neurologist to help him with the Botox or for a baclofen therapy, so that I get the tone that I need, because these robots have their own minds. So if you put a patient who has hypertonicity in a robot, you may actually damage that patient. So first is you have to make sure that you have a spasticity of not more than grade 1 plus to 2. If you have a grade 3 more than 2 spasticity or modified Ashworth score, then I would not initially use a robotic system. I would first try to manage that patient manually through various our therapeutic techniques, and then once I have a patient who is fit enough to be taken on a robotic system, I would do that.
Now, this is my question, which I want to ask you. In your
Yes.
experience, what are the primary clinical trade-offs between using wearable exoskeletons versus end effector based systems for gait training?
So let me tell you, first is the cost. End
Okay.
effector runs in crores. End
Okay.
effector runs in crores for an end effector device. A simple device may be costing you around 2 to 4 crores, versus a exoskeletal device which may cost you under 1 cr. And there are now exoskeletal devices available which may cost you for between 20 to 40 lakhs. So that is one thing. On ground training is definitely better in exoskeletal. Ease of therapy, less space occupied in your rehab area, because space is always a constraint with rehab. So within the given space, and exoskeletal fits better. And you have the therapist has much more control. Like I said, if you have a patient who's on a end effector or a Hokoma Locomed for that matter, and if something happens on that machine, it takes at least 5 to 10 minutes to take off the patient and get him to the lying position, versus a patient who is an exoskeletal. You have to just get the patient on a lying position straight away. You saw the how the therapist was holding that patient from behind, and if for god forbid anything happens, you could easily get the patient down. So it is more safer for that matter. I would not say the other one is not safer, but you have to be a little more vigilant.
And there ends all the questions. Thank you, Dr.
Thank
Tarun,
you.
for the fantastic session.
Thank you so much.
It's
My pleasure.
exciting to see how these technologies are evolving to support both the therapist efficiency and
Absolutely.
patient
And let me
and the
tell you
patients.
now, yeah, India is not far away, where you have, we have patients coming from all over across the world to us in India. I think we are making our mark there. Thank you so much
Yeah.
for giving
Yes.
me the time and opportunity.
Now let me introduce the last resource person, Dr. Manu Raj. He is a leading neurophysiotherapy professional specializing in neuromodulation and neuroplasticity-based rehabilitation. With over 5 years of clinical experience at Apollo Specialty Hospitals and as therapy head at HCAH Suvitas, he brings extensive expertise in advanced inpatient and neurorobotic rehabilitation. He has received international training in cutting-edge robotic neurorehabilitation technologies, including Cyberdyne HAL, Japan, Luna EMG by Exotech, Poland, and BCI Recoverix by GTech Medical Engineering, Austria, integrating robotics, brain-computer interface systems, and neuromodulation to enhance functional recovery. An alumnus of RV College of Physiotherapy, he holds a master's degree in sports physiotherapy and currently pursuing a fellowship in neurology. Dr. Manuraj was a featured speaker at PhysioCon 2025, where he presented on robotics redefining neurorehab. He is committed to advancing evidence-based neurorehabilitation and empowering patients through technology-driven recovery solutions. His presentation topic today is Technology-Driven Neurorehabilitation, BCI, Cyberdyne, HL, Luna EMG Systems. Over to you, Dr. Manuraj.
Good evening, everyone. Thank you, Dr. Purnima, for the brief description about me. Thanks for that. So, I would like to start with my topic. I'm Manuraj, heading the therapy at Walk Again Advanced Neurorobotics Center again. Once again, I just to introduce myself. So, my work focuses on integrating robotic rehabilitation, neuromodulation, and neuroplasticity-based therapies to improve the outcomes for patients with neurological conditions. So let me just share my screen. So today I would like to talk about technology-driven rehabilitation. Neurological recovery has traditionally relied on manual therapy and repetitive exercises. However, with the advancement of neuroscience and technology, we are now able to enhance rehabilitation using innovative tools that directly stimulate neuroplasticity and motor relearning. Technologies such as brain-computer interface, if you would have heard, systems like Recoverix and robotic exoskeletons like Cyberdyne HAL, EMG triggered rehabilitation devices like Luna EMG, and functional electrical stimulation systems like XTEP Neuro device, which was recently uh, uh, displayed in a Shark Tank episode by Dr. Parag, who was the founder and CEO, and more intensive, measurable, and patient specific therapy. So, as Dr. Tarun and Dr. Ramesh has already spoke about neuromodulation and neuroplasticity, I don't have to elaborate the points again. I know, but still, neuroplasticity, as you know, is the brain and nervous system's ability to adapt, reorganize, and form new neural connections. I'm just making it very simple since they have already told about what is neuroplasticity and neuromodulation. Neuromodulation refers to use of targeted electrical or magnetic stimulation to influence neural activity in the brain, spinal cord, or the peripheral nerves. So techniques such as RTMS, the transcranial magnetic stimulation, which is a non-physical side of the therapy, spinal stimulation, and functional electrical stimulation helps activate dominant neural circuits, improve motor control, and enhance the brain's capacity for neuroplasticity. So we'll directly go to the first device. I would like to briefly talk about Cyberdyne HAL, which stands for Hybrid Assistive Limb. It is an advanced robotic exoskeleton. This is world's first brain-controlled wearable exoskeleton. This is nowhere in India. It is used till now. Only Rockagain is exclusively using Cyberdyne. It is developed in Japan that assists patients in performing voluntary movements. So unlike the other exoskeletons which you would have already seen, like Locomat, Walkbot, Gaton, and any other centers in India, this is entirely different because the device detects very small bioelectrical signals generated from the brain and the muscles when a person intends to move. And it supports that movement through robotic assistance. So I'll show you a small slide on this. So ideally, the brain has to think and send the signals to the muscles. The muscles will read it. That's the bioelectrical signals which catch through the very surface electrodes which we place on the hip flexors and the extensors in the brain, and determining the movement. Then with the recognized motion, the HL, the hybrid assistive limb, distributes power to the exoskeleton, and then performing the movements, the HL stimulates neuroplasticity. So this is how it works. As I said, HL is widely used in neurorehabilitation for conditions such as spinal cord injury incomplete, stroke, and other neurological disorders. By enabling repetitive task-specific walking training, it can help improve the gait pattern, muscle activation, and functional mobility in patients with any neurological disorders. Coming back to a small video. This is a video which I have made in my own center. Sorry, yeah, my own center where I wanted to show you all the fixing part also, because ideally the patient will be wearing a harness and will be suspended over a harness with the help of something called meadow that controls the to and fro, the up and down movement. And once the patient is connected to the meadow with proper support, so that we make sure that there is no fall, the robot, which weighs around 14 kg, will be fixed behind. That's the wearable exoskeleton. And once that is fixed, we have modalities which can be used to control the activities of the patient as per the patient's intent to move. So it works, as I said, by detecting this bioelectrical signals. These are the electrodes which we place on the flexors and the extensors, and it's connected to the robot suit. The device interprets these signals and assists the patient in performing the movement, creating a feedback loop between the brain, the nerves, and the muscles. So this process helps stimulate neuroplasticity. This is a small module which controls all the hip, the left and the right side is distributed equally, so that we can select the assistance level, the torque level, and the sensitivity level, and the control mode. If you see, the control mode is in CVC. I'll come to the control modes which the Cyberdyne has. So it helps stimulate neuroplasticity, allowing the brain to relearn and reorganize the movement patterns. So uses in neuro rehabilitation, I would say it is very commonly used in stroke patients. Pediatric robots are not in the markets yet. So this is a training which happens in the treadmill, but we have overground walking on the track. The meadow can control the walking on the track. So there are two forms of walking. One is the surface will be moving. The other one is the surface is immovable. So this will be taken over before after a gait assessment. So we place the motion sensors on the dorsal aspect of the feet and make a patient walk to determine the gait pattern. Gait analysis will be done on basis of the motion sensors with the quantitative data, the stride length, cadence, velocity, and things. And then the basic control function, as I came to the cybernetic voluntary control mode, because the voluntary control mode CVC, when we come to it, it works on the bioelectrical signals, as I said, from the flexors and the extensors muscle groups. So adjustments are controlled by these three parameters: sensitivity level, torque tuner, and the balance tuner. CAC, which is cybernetic autonomic control mode, can be with the based on the preset leg movement patterns. I would say for mild cognitive uh, deficit patients, we can put CAC mode, because CVC there won't be any voluntary activity, or if we give repetitive cues also, sometimes they won't recognize the movement or recognize, or we won't be able to do the movement. So that is a difference. And CIC, there is an impedance mode which can actually, based on the joint motion, which can the product can exert a torque and move. So these three modes are widely used for Cyberdyne. And Cyberdyne also, the company also has single joints for strengthening part. So this different modules of single joints which focuses on strengthening activities like wrist, elbow, knee, ankle, and lumbar joint. Ankle is not in the markets as of now in Bangalore. So HL moves as you intend, same as as I said, the targeted muscles, which helps in neuromodulation and neuroplasticity. I've just put few photos of the joints which we use. This is for the lumbar joint, which can actually strengthen your lumbar joint, the trunk or the core muscles. The activities followed with this cyberdyne lumbar joint will be sit to stand, squatting, or maybe walking, forward bending. All these activities can be done. The robot will assist in the same way like Cyberdyne HAL, the wearable exoskeleton, which we already saw the video. It works on that basis, the same basis with the bioelectrical signals. So we can set the assistance level as per the patient's tolerance and the patient's intent to go. Same happens with the knee single joint that is for the knee, which you have seen the photo. And this is for the elbow. The small module which you see with where there is a graph will show the bioelectrical signals which is generated. And then coming to the next device, that is called Luna EMG. So Luna EMG is an advanced robotic neuro rehabilitation device designed to improve upper limb function, coordination, and motor control in patients with neurological and orthopedic conditions also. So this works using electromyography, EMG sensors, to detect the muscle activity from a patient. The system provides real-time biofeedback and interactive therapy exercises, allowing the patients to perform different tasks or task-oriented, I would say, and game-based rehabilitation also. So the device helps the therapist to deliver high-intensity repetitions. That's a plus point in the robotics part. The repetitive activities, the goal-oriented training, and there is a feedback. There is a proper data which we have, like a history on a daily basis. So I'll directly go to the this is a photo of Luna device, which the module and the tab is connected for the live muscle firing from the EMG electrodes, and the recliner chair where patient can sit, patient can lie down prone, patient can be in supine, sideline. I'll just move the body. So I hope everybody can see the video. So this module is only for the shoulder flexion, which we are seeing now. This has all the modules like shoulder flexion, elbow flexion extension, wrist supination, pronation, knee flexion extension, hip flexion extension, adduction, abduction, ankle, dorsiflexion, plantar flexion. All the movements can be carried out with different modules. We'll be fixing. See, if you see that this is the ankle module, but this is not a passive device which just uh, make the patient do activities. No, this is purely based on the EMG signals. The therapist will see the live feedback of the muscle firing as per the potential of the patient signals. We can set the threshold on the device, and then if there is 5 to 10% of initiation from the patient, the robot will push it for the complete ROM or the complete movement. That's how Luna EMG works. This is from Exotech from Poland. It's a very sophisticated device, and there is no alternative as of now in India. Rimo is a small device which we can't compare because this is completely EMG based, EMG triggered. So I would say this is a very good device. If you get a chance to explore it, you should not miss it. And coming back to the next innovative application which we are following is Recoverix, BCI Recoverix, the brain computer phase interface. This based neuro rehabilitation. This is developed by GTech medical engineering team from Austria under Dr. Christopher Guber. This helps patient regain the movement by directly connecting the brain activity with the muscle movement. So how it works, the system records brain signals. We keep EEG cap on the scalp while the patient imagines the movement. It is motor imaginary. Moving the limb such as the hand or the foot, we concentrate on the smallest movement such as dorsiflexion of the wrist or dorsiflexion of the foot. When the system detects the correct motor intention, it provides a visual feedback through a virtual avatar and triggers functional movement, electrical stimulation to produce a real movement. So that's how BZA works. This creates a closed loop between the brain and the muscles again and helps promote neuroplasticity and motor relearning. So this motor relearning, when we talk about motor relearning, I'll show you a small video of how BCA recovery. This is a photo how it looks like the therapist who assists the patient in case if they need a help in identifying the avatar movement or any stimulation difference or something. Just directly go to the video. So this is the EEG cap, which I was mentioning, which has 16 EEG leads, where the functional connectivity of the brain waves are directly transferred to the functional electrical stimulator, which is kept on the dorsiflexors, the flexors of the wrist. Complete the video. The gel is to avoid the friction. Then it will be connected to a battery, and there will be an amplifier fixed. This is completely non-invasive. There is no point in patients getting tensed or worried about what will happen to me, such things. The earphones are to avoid any other artifacts when we carry on the session is going on. We concentrate on the contralateral sides, maybe the dominant side and the affected side should be concentrated with the electrodes. The functional electrical stimulator, which you can see causes the dorsiflexion. This is motor imaginary. The patient is just imagining the movement with the avatar, and then the movement happens. There is calibration mode, training mode 1, training mode 2. Repetitions 80, 80, 80, 240 movements. And after 25 sessions, you are getting 6,000 movements. The brain is naturally getting trained to control your muscles and start the movements. So this is called neuroplasticity. This is how BCA recovery work. And it is mainly used in rehabilitation with patients in stroke, multiple sclerosis, traumatic brain injury, spinal cord injury, Parkinson disease, and other neurological conditions. So it promotes neuroplasticity, as I said. It helps activate the motor areas of the brain during the motor imagination by strengthening and forming new neural connections, supporting the brain reorganization, and improves motor recovery. Patients can improve hand, arm, and leg movements. This is purely the assessment scale what we use before starting a BCI recovery session would be Fugl-Meyer assessment for the upper limb. And after 25 sessions, we do a reassessment on the Fugl-Meyer to see the changes. And as I said, it improves the motor recovery. It restores the brain muscle communication, reduces learned non-use, I would say, because encourages activation of the affected limb, especially in stroke patients who tend to avoid using the weak side, and improves functional outcomes. Patient may experience improvement in movement control or coordination and daily functional activities, and enhances patient engagement, of course. So coming back to RTMS, connectome gated RTMS. Why connectome gated? I would like to receive a few questions on that. Is an advanced neuromodulation approach where brain stimulation targets are selected based on the patient's individual brain network connectivity. So that is how RTMS works. It is called repetitive transcranial magnetic stimulation. The word connectome is the complete map of the neural pathways and connections in the brain. So what we do is initially we send the patient for doing a functional MRI, unlike the normal MRI, which functions in the terms of BOLD technology, the blood oxygen level dependent. The functional MRI will give us the functional connectivity of the brain. We send it to process for the brain mapping. Once the brain mapping is done, and when we get the points which are affected, we mark the points as you know the sensory motor DLPFs, the dorsolateral frontal three cortex, sensory subcortical, the cerebellar for balance coordination. So there are multiple connectivity on the brain. So this is a non-physical part of therapy what I'm talking about, but to improve associated factors like spasticity, bowel, bladder, cognition, speech, where we know that on the left side of the brain we have Broca's area, Wernicke's area, which controls the speech or the language or pathology and things. But still, we doesn't know for the particular condition or for the particular patient what connectivity, what is the connectivity, what is exactly affected. So to find out that connectome, we send the patient for the functional MRI. Once we receive the points, we actually uh, code the MRI to our neural navigation device, and then we start the stimulation. So the target areas the patient undergoes once the patient starts with the therapy. There, the coil which you are seeing on the photo, it is an 8-point coil which creates an electromagnetic field around your scalp. So I'll show you a small video so that get a better picture about it. I hope everyone can see it properly. So this is the module which we use to control the intensity, unlike what we use in TENS IFT, for the stimulation control. This also has points which are hypoactive and hyperactive, depends on the condition. And this can be used for, before stages, it was used mainly for psychological disorders. After 2008, it was FDA approved to use for stroke conditions, traumatic brain injuries, Parkinson disease, incomplete spinal cord, or any other neurological disorders also. Dementia, ADHD, CP, autism, all cases also were treated with TMS to some extent. This is a coil which creates that field, and the particular point will be targeted. And thus, stimulating such areas deep into the cortical structures of the brain can actually evolve neuroplasticity. So that's how the TMS works. So if you can see the waveform, it is continuous and intermittent, ITBS and the CTBS forms. So then it can modulate that specific network rather than just a general anatomical location. And coming to another non-invasive spinal cord stimulation, I would say it is an advanced, again, neuromodulation therapy device to improve walking balance and motor function in patients with neurological deficits. This XSTEP delivers, XSTEP was recently in the Shark Tank episode by Dr. Parag. So this delivers non-invasive electrical stimulation to the spinal cord through surface electrodes placed on the skin on the spinal area. We focus, suppose for the intrinsic control of the spinal networks on the lower limb, we focus on T11, T12, L1, L2. As you know, the L2 level, the spine closes. And so whatever the myotomes serve, we have to stimulate on that particular area non-invasively. Invasively, there are techniques like epidural stimulation surgeries for spinal cord injury patients. So unlike spinal cord injury cases, any cases we can focus exclusively. And thus stimulating the activates the spinal cord circuits responsible for movement and helps improve communication between the spine, brain, spinal cord, and the muscles. So it is usually combined with task-specific activities like stepping, gait training, or which enhances the motor learning and promotes neuroplasticity. So this is powered by Spinex, and the company name is Vivatronics, and founder is Dr. Parag. So as I said, this device, this is how it looks like. It is, and this uses electricity to amplify the nerve signals to restore the function, a hearing aid for the spine. So this is under FDA approval, CDSU approved in India. So the photo will tell you about the placement of the electrodes. There will be the ground electrodes will be placed on the SIS part, the bigger electrodes which you're seeing. I can show you a recovery video of few patients. I won't say a recovery video because currently we are using for cases like spinal cord incomplete, CP, children, spina bifida, and different neurological conditions. I'll play a small video on that. This is an incomplete spinal cord. You can see the device connected while the activities are carried on. So as I said, this is activity based. We can't give the stimulation when the patient is in idle position. Patient has to be doing an activity. So this is again a CP child. So this is all the boost on with activities for walking. We have seen good results in terms of bowel bladder dysfunction getting better, spasticity getting better, the muscle tightness getting better. For few patients who had spasm and clonus also, we had seen good changes after stimulating. All depends on the biphasic current, the electrical stimulation, pulsed electrical stimulation, what we use for. So this is about XTEP. To end up with, I'll just show you a small video of a walk again patient. Single 40-year left basal ganglia bleed. Before and after videos of how he has improved from robotics, exclusively robotics. I would say Cyberdyne HL, BCR Recoverix, Luna EMG, the devices which we were talking about. This is a journey from day 0 to day 40. This is actually a Delhi center in Lajpat Nagar, attached with the Institute of Brain and Spine Hospital. You could see the speech improved, targeting the speech circuits after the TMS session. So neuromodulation based neurorehabilitation was started in IVS hospital in 2020 by Dr. Sachin Kadari. Then started other centers by the name of Walk Again in Malaysia, Muscat, Hyderabad, Bangalore, and Oman. Walk Again is growing its reach outside throughout Southeast Asia and other bringing more advanced neuro recovery services to more patients. Coming soon to Dubai and other major cities. Please feel free to do some field visits or know more about the technology what we use. I'm attaching my address my mail ID, my official and my personal mail IDs. I was getting many inquiries from IITs, India and other medical engineering teams to develop such robots in India. That's it. Thank you.
Thank you, Dr. Manu, for sharing your experience with the Walk Again protocols. There are few questions. Let me start asking
I'll
one
just
by
stop
one.
sharing my screen.
Yeah, you can stop that. So first question is,
Wonderful session.
how do you determine which of the three control modes, that is CVC, CAC, or CIC, is most appropriate for a patient at different stages of their recovery?
That depends on the gait analysis what we take from the sensors. As I said, we when we keep the on the dorsal aspect of the feet and we take the gait analysis and we record the video when we see if there is a circumdactic gait and if the patient's initiation, suppose in simple, if it is a hemiplegic patient and there is very less muscle strength, the patient is like hardly can walk or walking with a walker support. So we detect, we see the walking pattern, how the patient's initiation is, and depending on that, we have levels from A1 to B10. So B10 being the maximal support from the robot. CBC is by default for any good cognition. I mean, if the cognition is not impaired, we fix CBC for all the patient, the voluntary control. And then we will set if the patient's initiation is really less, that and if the robot's initiation is required more, we will keep it at B10. And if we see that the patient's initiation is better than the robot, or it's actually in his good control, we will reduce it from B10 to A5, it will come. So what I mean to say is A1 being the better sign. When we keep the assistance level or the sensitivity level to A1, that means the patient's initiation is more and the robot's initiation is very less. So we mark the progress on a basis of maybe after 5 sessions or 10 sessions, we see that the B10 comes to A1. So that marks the improvement of the patient. So that is how it is determined. And for mild cognitive, as I added mild cognitive impaired patients, we keep CAC mode because sometimes the voluntary initiation won't be proper even with cues. So that is how it is matched. I didn't mention about the A level and the B level. So I think now it is very clear about how we can set the assistance level from the robot.
Are there specific bioelectric signal thresholds required for a patient to be a candidate for the cybernetic voluntary control mode?
You mean to ask, is there any limitation from taking the bioelectrical signals?
No. Any bioelectrical signal threshold are required for a patient?
No, bioelectrical signals itself is like a very surface electrodes will catch the small reflex. So there is no difference in that. Even with a small reflex, with a small muscle jerk, the signals will be caught. How strong it is, we will get to know from the device itself. For complete spinal cord injury patient, the bioelectrical signal will be absent. So for sure, we won't be able to deliver the therapy. So it's simple. Yeah.
Another question is there. You mentioned that HAL stimulates neuroplasticity through a 5-step feedback loop.
Yeah.
How many sessions are typically required before measurable changes in voluntary motor control are observed without the device?
Ideally, when one session will be of 45 minutes, as you know that the patient, if they're walking one round, it is almost 10x times when they walk for 45 minutes. So ideally, I would say that I have seen good progress in 25 sessions having 6,000 movements, and then it causes neuroplasticity and the voluntary movements has come back and the patient dependence has come down, confidence has come up, and the fear of fall has reduced, and obviously the gait patterns will change. And as we record it in a quantitative data where we are not manipulating with verbally with anything, so we record it as quantitative data: the stride length, the velocity, the swing phase, the stand space, TUG, and the 10-meter time taken to complete and things with a video. So we record that and keep, and so after 25 sessions, we have seen good improvement in patients because these repetitions can always help in neuroplasticity.
How safe is TMS? Any complications of it?
Yes, that's a good question. Actually, for patients with BP shunt, where the pressure has to be stabilized, or patients with recent seizures, we would not advise TMS. And TMS is completely safe because it is non-invasive. But only for patients who are under anti-seizure medicines, we we will ask them to wait for the seizures to come down the frequency. At least in the last 3 months, if they have seizures, we don't take them for TMS, since it is a magnetic stimulation. And even if there is a metal implant in the skull, it's fine. Unless it is if it is a titanium like non-ferromagnetic metals like titanium, we can go ahead with the magnetic stimulation. So there are it is FDA approved on that part also. And coming to any open wounds or pregnant ladies and pacemakers, we restrict the therapy. We don't allow them to take the therapy. Otherwise, it is completely safe. 1 in 100 patients may complain about a mild headache on a day or two, and we will stop the therapy if that is the case, and then we will restart the therapy after 2 3 days. Other than that, I have not seen any other major drawbacks or limitations on our treatments.
For the LUNA EMG, how does the system distinguish between intentional muscle activity and involuntary spasms or tremors to trigger robotic assistance?
That's also a quite good question, because actually I expected a different question about the spasticity part. But I would say that if there is spasm, if there is spasticity, the movements are always, we would say it's a false movement. So whatever the movements happen, if Dr. Tarun has already described about spasticity part, if the spasticity modified Ashworth scale shows more than value more than 2 or above, we would not advise them to initially go for the robotics for sure. If there is, even if there is spasm, clonazole, so myoclonazole, would initially advise them to start with medications like baclofen, leofen, XL or something, or to go for Botox or baclofen pumping, and then come back. And along with, I mean, the conventional therapy has to be continued for sure to reduce the spasticity. At least if it comes down the modified Ashworth scale to one plus, we can start giving, because the signals will be fake. I mean, it can be false signals. So we don't promise anything as such.
There is one more question. Can the BCI Recoverix technology be used simultaneously with the Cyberdyne exoskeleton?
Yes, we are using that. BCI for multiple sclerosis patient, for cases for with secondary progressive multiple sclerosis patient, they would advise taking only BCI recovery sessions to show outcomes like better control on the limbs and better walking, since it is a transverse kind of deficit. But we combine BCI, Cyberdyne HAL, Luna EMG to club and get better results. So there is no problem with that. No harm. We can always do that. It's an integrative therapy. Definitely, we would go for that.
There was one question which I missed in to Dr. Tarun, and this question is applicable to you and Dr. Tarun both. What are the charges for per session if we are using robots to treat patient?
Okay, I can say it comes around 9,000 to 10,000 per day for integrative therapy, because it is not only the HL which we are going to assign for a patient for 45 minutes. No, BCA recoveries will be for 1 hour, Luna EMG will be for 45 minutes, and an integrative coordination station like Pablo, timer for standing balance or coordination, proprioception, conditioning will be assigning. That is also for 45 minutes. So ideally, the patient is spending around 4 hours in our system, and that marks a difference, and that speed ups the recovery. So ideally, I would say it comes around 9,000 to 10,000.
So I would also like to answer that, Dr. Purnima. Thank you for
Yes.
asking that. So I would like to ask you how much does a therapy cost for 45 minutes in a good clinic? How much do you pay for a therapy at good clinic for a session of 1 hour, if not 45 minutes, roughly?
It is four to 5,000 to people. Then now people are charging
For one session.
It's less than that.
Yeah. Okay,
Here
chalo,
in
let's
Bangalore,
yeah.
in Bangalore, the session charges are 1,500 to 2,000 rupees.
Yeah. So one session for 2,000 rupees, and here, like you said, this is a comprehensive rehab where you're spending actually 4 to 5 hours. So you can just multiply that, and that is the cost straight away.
Okay.
It's
Nothing.
actually
So
less than comparatively.
yeah. So let's So
Okay.
it's nothing exorbitant. It's nothing like that. It's just a simple mathematics. If you just if you are there for 4 hours, even if it's just such high technology, if you're paying 7 to 8,000, I don't think that should cost too much. Yeah. Thank you.
So this was the last question. There is some update. I think Dr. Neha, you can take up that.
Hello, good evening, everyone.
Good
Yes,
evening.
it was beautiful session by all three speakers. Thank you so much for this informative session today and to the moderators, ma'am, and Dr. Uttara.
Thank you.
Yes,
Thank you.
and just to update this, that as we are having this Asia Western Pacific Regional Conference, Physiotherapy Conference in India, as IAP hosting it, and this conference has extended the early bird registration till 31st of March, 2026. So early bird registration can be availed till the end of March to all. And we shall share the details of registration on the website that you follow for the AWP. You will find all the details. And for the flyers, we shall share it to you on the WhatsApp group as well. So this was one of the updates. So whoever are interested, definitely go ahead with the registration for AWP Regional Conference. The venue is going to be Yashobhumi Convention Center at New Delhi. And the dates are 26th and 27th of September 2026. Over to you, ma'am, for this. This was just
Thank
for
you
a
so
very
much.
short update. Yes,
Yeah,
ma'am.
thank you, Dr. Neha. That was very important. Now, on behalf of the IAP Neurology subgroup, I extend my heartfelt gratitude to our distinguished speakers, Dr. Ramesh, Dr. Tarun, and Dr. Manuraj, for sharing their valuable insights and expertise with us today. A special thanks to my co-moderator, Dr. Uttara Mohan, for assist in facilitating this online symposium. We are deeply grateful to our IAP President, Dr. Sanjeev Jha, and to the National Head of the IAP Women's Cell, Dr. Ruchi Varshne, for their constant support and encouragement. Most importantly, I thank our wonderful audience for their active participation and engagement, which makes these sessions truly meaningful. Together, let us continue to advance physiotherapy and neuro rehab for the benefit of our profession and society. Thank you all. Thank you so much for
Thank you.
joining our symposia.
Thank you once again. Thank you,
Thank you.
everyone.
Thank you.
Thank
Thank
you.
you all.
Thank you, Dr. Purnima. Thanks a lot.